So the first part of midline insertion is obviously to prepare your equipment and position the patient. In this case, the patient is positioned supine with his left arm abducted at 90 degrees, resting on a cushioned surface. We've got the equipment tray, a stool, sharps box, and the ultrasound screen positioned in front of the operator, so we can directly visualize what's going on with the needle cannulation in the vein. This is the equipment tray fully set up. Before we insert any midline or PICC line, we usually carry out a pre-procedural ultrasound scan of the upper medial arm, just to check the suitability of the basilic vein. We look for size, position, compressibility, and we usually scan up and down the arm to make sure that it's patent for a reasonable distance up towards the axilla. In this case, the basilic vein does appear suitable, and therefore we'd be happy to go and scrub in, get the equipment ready, and proceed. Because it's an aseptic technique, we're then cleaning the upper medial aspect of the left arm after the tourniquet has been applied. And again, give it a nice clean around this area so it's all aseptic. So give a little bit of time for the cleaning solution to work. Then you lift the patient's arm up, put the under drape down, and then we apply the over drape, which has a circular opening to allow you access to the basilic vein for cannulation. As you can see, we're also wearing a surgical gown and gloves, and the ultrasound probe is covered as well, and we're using sterile ultrasound jelly. Now the operator sits down so he's comfortable. Orientate the ultrasound probe correctly, place it over the area where you expect to find the basilic vein, identify on the ultrasound, and then inject a small amount of local anaesthetic directly over where the vein is, so that the skin is anaesthetized and the tissues above the vein will be numb for when you insert the main needle into the arm. So we insert the needle at an appropriate angle through the anaesthetized area, and as you can see, the vein is in the center of the screen, and as the needle is coming in, you can see the top vein wall being indented down. It's important to take your time with this process and make sure that you target the vein ideally on the top surface. At this point, we've just adjusted the focus so that it's centered on the needle tip, which is currently compressing the vein. Often the needle tip will indent the top vein wall, and around this point it requires a small gentle thrust to actually penetrate the vein wall and enter the lumen. As you can see in this case, it's taking a little bit of time, which is not unusual, but again it's important to keep the vein in the center of the screen and adjust both the needle angle and direction, and also move the ultrasound probe up and down using both your hands so that you penetrate the vein in the right position. Once you've penetrated the vein, there'll be a flashback of blood from the needle, and you should then advance the guide wire through the needle and into the vein. At this point we're just confirming that we're in the vein, which can be seen as a white dot in the centre of the vein there. So we're confident we're now in the basilic vein. Now you can secure the guide wire in position and remove the needle. Make a small nick in the skin over the guide wire where the patient has already been anaesthetised. And this will allow you to insert the sheath over the guide wire into the patient's arm and into the basilic vein. And as you're inserting the sheath, make sure you've got control of the guide wire because you don't want to lose that. At this point, we will remove the inner sheath and guide wire. And as you can see, there is blood coming back, which confirms we're in the vein. You advance the midline, which has already been flushed with normal saline. And again, you can see blood coming backwards, which confirms you're in the vein. Now you snap the outer sheath and separate it with both your hands, at the same time making sure that the midline doesn't come out. This can be sometimes a little bit tricky, but again, just be patient and it'll come out. Now, if you lift the sterile sheet up and ask your colleague just to release the tourniquet and put the sterile drape back down. So once you've actually got the midline in the arm, because we've made a nick in the skin and we're using ultrasound jelly, it's likely around the area of the skin where we want to stick the midline line is going to be a bit wet and slippy. So at this point you can use some swabs, wet or dry swabs, to clean around that area. Now once you're confident the midline is in the right position, you can secure it down to the patient's skin using a sutureless attachment device, as seen here. This can be somewhat fiddly to attach, so just take your time and make sure that the patient's skin is clean and dry. Now at this point, unclamp the midline, remove the inner stylet, take your normal saline syringe and aspirate it and flush with a push-pause stop-start technique. Reclamp the line and attach the device at the end of the midline. Now at this point you can remove the top drape and apply the rest of the catheter fixation device so that it's securely in place. It's also important to put the midline label so that everyone knows exactly what the line is. And just for confirmation, you can use your ultrasound again just to check that the line is in the vein. And there you have the finished product.